Hey everyone, so a big welcome to oral pathology, and we're going to talk about the blood, which is the systemic units, and blood is going to form a lot of correlation with a lot of subjects. But before starting, I would like you to tell you that if you have come here without watching the physiology blood videos and the hematology videos of physiology, then please go back, stop right now and finish your physiology first, which is the blood portion, and then come over here, because this would be a little faster and you would be able to correlate better in terms when you finish physiology. Okay, so the first thing which we are going to talk about right now are anemias. And if we talk about anemias, the first thing which we are going to talk about is macrocytic megaloblastic anemia. Okay, macrocytic megaloblastic anemia. And to understand the terminology here, first of all, we have to understand the counts which are associated here. So the three counts which we are going to take a look at are the MCV, the MCH, and the MCHC, which we've already discussed in physiology. So the MCV is the mean cell volume, and that is the size of the cell. If we talk about the mean cell volume, the range roughly lies around 82 to 96 femtoliters. Now, if the RBC size is less than 80, then the cell is considered to be microcytic. And if the size is quite large, let's just draw the small one here, and if the size is large and let's say it is greater than 100 femtoliters, then the cell is considered macrocytic. Yeah, okay. So next what we are going to talk about is the second word here, which is the MCH, which is the mean corpuscular hemoglobin, and the range for this is 27 to 33 picograms. And next is the MCHC, which is the mean corpuscular hemoglobin concentration, ranging from 33 to 37 grams per deciliter. Okay, so how do we remember these? We have to remember from 27 to 37, and from 27 to 37 it is going to cover both the values. So just remember the digits 27 to 37. From 27, the middle point roughly is 33. You reach 27 to 33, you'll get the value of MCH, and 33 to 37 would be the value of MCHC. Okay, so when we are going to talk about the development of the RBC, if you have studied the development of the RBC, the RBC was developing, the immature RBC was having a big nucleus here, and it was even bigger in size. And as the cells matured, they were converting from bigger size to smaller size, isn't it? We've discussed here. So the bigger RBC, if you remember, was called as the proerythroblast. Okay, and then when it was reducing and maturing in size, it was converted into early normoblast. Okay, it was converted into early normoblast, and then it was converted into intermediate normoblast. I'll just write intermediate normoblast. And if you remember, the intermediate normoblast was also called as the polychromatophil erythroblast. Now polychroma, why? Because poly means multiple and chroma is colors. This is where actually hemoglobin starts to appear. So you see, the early normoblast was bigger in size. The proerythroblast was the biggest in size. The early normoblast is somewhat intermediate in size, and you can see that the nucleus is shrinking. The intermediate normoblast, which is polychromatophil erythroblast, is more lesser in size, and let's just see what will happen here. It is going to have this nucleus in the center, And now for the first time, even the hemoglobin which starts to appear. So you can see this cell now appears two colored or multiple colored, and that's why it is called as polychromatophil erythroblast. From the bigger immature cell, it is now converting into the mature cell, and the mature cell right now we see the stage which is multicolored here, and that's why it is called as polychromatophil erythroblast. Ultimately it's converted into late normoblast. Okay, it is converted into late normoblast, and from here it is converted into the reticulocyte. Reticulocyte is almost the same size as the RBC, and this now matures into the RBC. So we've seen these stages, we've seen these cycles here as well. So now what happens, you see, whenever these cells, whenever these reticulocytes, see, where is this whole process taking place? This whole process basically is taking in this, I'm just drawing a bone here. It is happening in the bone marrow. So these cells are being formed here in the bone marrow. Let's say you reach to the stage of reticulocyte, and from the reticulocyte, these cells now reach into the circulation. So where are these cells forming? These cells actually are forming in the bone marrow, and ultimately what you find is that these cells are reaching into the circulation. So whenever the cells are forming in the bone marrow, they are called as blasts. And when the cells mature and they reach here into the circulation, they are called as cytes. Getting it? So two terminologies. And if you see this anemia which we are going to talk about here, it is macrocytic. That means big cells which are in the circulation. Megaloblastic, blast cells also bigger in size, and all of this resulting in anemia. So the whole condition which I am actually telling you here is macrocytic megaloblastic anemia, and that means that these cells now are a little immature and they have straight away reached into the circulation. Immature cells reaching into the circulation, how it is happening? See what happens for these bigger cells, they have DNA in them as well, and when they are replicating, when these cells actually are growing, they require certain vitamins and minerals as well. And you have B12, and we also have folate, which is in synchrony. These two are required for the cellular maturation, which is the RBC maturation when it is growing. So when we are not getting adequate B12 or when we are not getting adequate folate, what happens is this larger immature cell is thrown out from the bone marrow into the circulation. It does not mature into that normal 7.5 micrometer cell. That is what happens here, and this is why we need B12 and folate for the maturation of these cells. The cells you see here actually in the anemias are not maturing properly, and when there is this deficiency in the bone marrow, and if a lot of deficiency of B12 and folate is there, then some other cells are also not maturing. In fact, what happens is that neutrophils also sometimes do not mature. RBCs as it is are not maturing because of the deficiency of B12 and the deficiency of folate. But sometimes what happens, even the neutrophils are not maturing. And the neutrophils, basically what happens is, see, let us just draw a neutrophil, okay? And let's say this is a neutrophil. Now this neutrophil will also move out into the circulation. And what happens is, as there is this young neutrophil, it is going to have a couple of nuclei in it. And let's say as the neutrophils mature up, the nuclei also tend to keep on increasing. And when the neutrophils mature up more, you can see the number of lobes or the nucleated material, the lobes are generally increasing. We have these multi-lobated neutrophils which are called as mature neutrophils. The younger neutrophils have, you can see, only a couple of lobes, maximum, or maybe 3 lobes, something like that. So what happens is that these multi-lobated neutrophils sometimes are also found in the circulation, and these are called as hypersegmented neutrophils. These neutrophils which have matured up are called as hypersegmented. What are these called? These mature neutrophils are called as hypersegmented neutrophils, and hypersegmented neutrophils generally are not found in the circulation. But then what happens is, if we find these hypersegmented neutrophils in the blood peripheral smear, let's say you've taken blood from the patient and you've taken it on a slide, even if you find one hypersegmented neutrophil, you will say yes, this is a condition of anemia. And if you find some macrocytes also in the presence of hypersegmented neutrophils, your diagnosis is confirmed as macrocytic megaloblastic anemia. Got it? So hypersegmented neutrophils are the older aging neutrophils which are rarely found in the circulation. Okay, they're not found because the half-life of the neutrophils is very less. In 6 to 8 hours they are being replaced. So generally we have these neutrophils which are the 2-lobed or the 3-segmented. That is what we find generally in the circulation. As they are aging, we find these hypersegmented neutrophils. The more hypersegmented neutrophils you find, that means the bone marrow right now is not able to divide properly and is not able to generate the cells somehow properly. That means the bone marrow is somehow in trouble. Okay, so later on what happens is, let's see, what is happening here is that bone marrow, if we see, okay, let's focus on the bone marrow. And if we focus on the bone marrow is responsible for the synthesis of RBCs. It is also responsible for the synthesis of WBCs, and it is also responsible for the synthesis of platelets. Now in macrocytic megaloblastic anemia, see what is happening is there might be a deficiency of B12 or there might be a deficiency of the folate. In fact, these factors ultimately are required by almost everybody. Initially RBCs are not being properly formed, you have megaloblasts into the circulation, later on WBCs are not being formed, you have these hypersegmented neutrophils in the circulation, later on even the platelets are not being formed properly, and a condition of overall cell count of RBCs also is reduced, WBCs is reduced, platelets is also reduced, and an overall condition which is called as pancytopenia results. But then pancytopenia happens in very severe conditions when the bone marrow is not working properly. Now what happens, as I was telling you, that rapidly dividing cells would require B12 and folate, and this is why the RBCs here are requiring B12 and the RBCs are also requiring the folate as well. Now there are some other rapidly dividing cells also in our body. Your gastrointestinal tract is also dividing and shedding of cells very rapidly. In fact, it has a very high turnover rate, and the cells of the GIT lining are also shed off very easily. So there also what's happening is GIT also requires the DNA for its development, and B12 and folate are not present for the replication of DNA and cellular growth, and somehow you find that GIT is also not properly being developing properly, and what happens is they are affected because those cells of the GIT were rapidly proliferating. In fact, the tongue, if you take a look at the tongue, so let me just clear this for you. And what we see is, if we take a look at the tongue, what we find is the tongue has multiple papillae. We had discussed in anatomy as well, the tongue has multiple papillae. In fact, what happens is when B12 and folate are lacking, your tongue is also a part of the GIT, isn't it? Yes, it's the first part of the GIT which you encounter in the oral cavity. So, depapillation results. Because of the folate and B12 deficiency, depapillation results because the papillae are not developing properly, and the tongue generally becomes reddish, swollen and inflamed, right? So this condition is called as, what is this condition called as? This is called as glossitis. And when the papillae are shed off, the tongue generally becomes smoother. Without any papillae, the wavy formation of the tongue would be gone. The tongue would become actually very, very smooth and very, very bald. Yes, so because of the depapillation of the tongue, there is glossitis and the tongue even becomes bald. Okay, so what actually happens is when the tongue becomes bald, the lower musculature of the tongue actually starts appearing. Papillae are gone, the tongue starts appearing bald along with the muscles beneath it. So it looks like as if the tongue is more like beef or beefy, and that is why we use a terminology which is called as beefy tongue. In fact, beefy tongue can be seen here. We will describe it later in the oral features, but I just got a little carried away, so I'm just telling you now that beefy tongue here can be characterized. Now these are multiple types of tongues, beefy tongue, raw beefy tongue, which we'll discuss, over a period of time, let's say 15-20 minutes as we are progressing through the lecture. But this also happens. So beefy tongue is seen, and we should not confuse with other terminologies and other nutritional deficiencies. Okay, so here what happens, this I'll just tell you, okay, if you're curious enough, the name here, this glossitis here is called as Hunter's glossitis, or Muller's glossitis. So this Hunter's glossitis or Muller's glossitis is a characteristic of B12, and it is a characteristic of the folate deficiency. And the anemia which we are talking about is macrocytic, because the macrocytes are in the circulation, and it is called as megaloblastic because even the blast cells of the bone marrow are immature, bigger in size. Now the question arises, this is the whole problem, the RBCs are immature and they have become bigger. How has it happened? So for this we have to understand and take a look at Miss B12. Right now see, she is not married and her condition is called as, who is this? This is Madam B12 and she is Miss B12. So Miss B12 is now taken here, and we can imagine this as the oral cavity. We can see these teeth as well in the oral cavity, and we can imagine that Madam B12 now is going into and is reaching here roughly around the stomach. Now when Madam B12 reaches here in the stomach region, she is kind of lost here. She doesn't know where to go. And when she doesn't know, okay, I'll just write here if you do not get confused here. So this is the college time, temporary time. I'll tell you why. Okay, so the madam here basically is getting confused and she doesn't know where to get absorbed. So what happens here, another fellow would come, you can imagine him like a special friend or whatever, boyfriend or whatever. So now he comes and holds the hand of Madam B12. Okay, who is this? This fellow is also called as the intrinsic factor. Okay, it is also called as the intrinsic factor of Castle or Castle's intrinsic factor. So who is this fellow? Now this fellow is Castle's intrinsic factor. He's holding on to the madam and is showing her the way. Where does this madam need to be absorbed? Okay, but before that I would like to tell you from where is this intrinsic factor coming from. Now if you've taken a look at the GI physiology, you would realize that we have certain cells here in the stomach, and these cells in the stomach are called as parietal cells. Okay, what are these called? These cells are called as parietal cells, or these cells are also called as oxyntic cells. And the parietal cells or the oxyntic cells which are present in the lining of the stomach are responsible for mainly secreting out two things. The first one is hydrochloric acid, which is for, the killing of the germs and clearing of the areas of the stomach. And the second thing which is being released is the intrinsic factor. Okay, so this is the second factor. That means this is the intrinsic factor which is being released here in the stomach via the parietal or the oxyntic cells, and this holds on to the madam and takes her to the destination. Now the question arises, where is the destination? This fellow knows. So if you see, the small intestine begins with duodenum, then you will reach jejunum. Okay, let me make it like this, jejunum, and then you will reach the ileum. Now the ileum, when it is about to end, it is the terminal part of ileum, and this is where madam B12 is going to be absorbed, and this is where the terminal part of ileum. Okay, I'll write it down if you will not forget. This is the terminal part of ileum where madam B12 is getting absorbed. Now madam is all happy, and she has now kind of taken care of intrinsic factor, utilized him, and she kicks him. Get lost, I'm through with you. College days are over. Now madam B12 is going to the liver, and in the liver she is going to be stored, and she is going to live here happily ever after, holding a hand of this fellow. Okay, right? So we will see now madam B12, where has she reached? She has reached the liver here, and now she is ready to get married. Okay, what about this poor intrinsic factor? Intrinsic factor is intrinsic factor. He'll say, okay, one is gone, another one will come. So what happens is, the intrinsic factor basically is sort of recycled from here, from the ileum. It goes back here and waits for another madam. That another madam will come from the mouth, and I will take her back to the terminal part of ileum. Madam will again kick him out, and he will go back again, getting it. So the intrinsic factor generally is getting recycled again and again, and you see the B12 madam is getting absorbed here. She is reaching here the liver, and this is where she becomes Mrs. This is where our B12 madam gets married and becomes Mrs. and is now settled happily ever after. Now who does she marry? Okay, the handsome fellow here. This handsome fellow is folate. Okay, so this is how the marriage is working. Madam B12 is settled in the liver, and she's going to live and be stored in the liver. In fact, in the liver, the folate is also stored, and both of them sort of need each other in the future life. Now, if you remember, okay, I'll ask you a simple question, general knowledge question, and you will answer it immediately. Who will live longer in life, madam or sir? Always remember, madam, females live longer. So madam obviously lives in the liver much more longer. Madam has a half-life of 3 to 5 years. Okay, right. Madam can live in the liver easily for 3 to 5 years, but this folate will obviously live lesser because he's a male, and so he'll get irritated by madam as well. So his half-life is, just imagine, it's actually in textbooks it is written 3 to 6 months, but just we will write 3 to 5 to correlate it with 3 to 5. But here the 3 to 5 would signify months only. Now 3 to 5 we'll just remember, and you can round it off to 3 to 6 months as well. So what we see is that Mr. Folate here can reside in the liver for 3 to 6 months, and then he or she would be finished, because he would be coming from folium, which is folate vegetables. Okay, if you're not eating green leafy vegetables, you can have folate deficiency. Okay, but now I wanted to ask one more question. Who is going to finish first? And obviously now you would be able to answer that folate is going to finish first. So now if I ask you, between B12 and folate, what is the more common deficiency that you are going to have? And the answer is that you're going to have the folate deficiency first, and this later on ultimately can be followed by the deficiency of B12, isn't it? Okay, so now let's see how do they utilize their time in the liver. So here what I have drawn is, I have drawn this folate, and do you know what is the active form of folate or the working form of folate? It is tetrahydrofolate. Tetrahydrofolate, THF. Why? Because he is having, let's say, 2 hands and 2 feet, so he's having 4 limbs. Hydrogen, hydrogen, hydrogen and hydrogen are present in each hand. In fact, he is holding on to certain dumbbells as well. Okay? And you just imagine that these dumbbells are methyl group, the CH3 group. In fact, the active form of folate is called as methylated tetrahydrofolate. Okay? So this is the form of folate which now is ready to act. How does it in fact act? This I'll show you. Okay, so what happens is, we'll see here, we'll have this DNA. Okay, this DNA, and DNA needs to replicate, right? So DNA needs to replicate. So the DNA attracts the tetrahydrofolate towards itself and it says, come and help me. Okay, the DNA says, come and help me, I am replicating, I am dividing and you are required here. Tetrahydrofolate says, yes sir, I am coming, at your service. So what does this tetrahydrofolate do? He would transfer the methyl groups onto madam. Now the madam actually holds on to the methyl group and it is no more present here with the tetrahydrofolate. Now tetrahydrofolate is free and tetrahydrofolate comes here. Tetrahydrofolate comes here to help out the DNA in dividing. Remember, he is holding on to the 4 hydrogen as well. DNA says, oh, you've come here to help me, I will break your hands. Now he is very upset because he doesn't have hands. He only has 2H now. The 2H actually have been, his hands have been this H and this H, which are the 2 hands, have been transported to the DNA. And the poor old tetrahydrofolate now has lost 2 limbs. Let's say it only has 2 legs and has converted into dihydrofolate. Okay, now he has converted into what? He has converted into dihydrofolate. This is where an enzyme comes into picture, and that enzyme is called as dihydrofolate reductase. Okay, what is this enzyme called as? This is called as dihydrofolate reductase, and this reconverts the dihydrofolate back into tetrahydrofolate. It's a reductase, so it will add the 2H back. He is very happy, and now this fellow runs away back into the liver, and into the liver he will take the weights from madam and say, okay, I've come back from the office and you can give me the weights which are the methyl group. Now you see, if B12 madam wouldn't have been there, if B12 madam wouldn't have been there, how would have the folate transferred the methyl group onto madam? Because if, let's say, madam wouldn't have been there, who would have held on to the methyl groups? And this is how what happens in B12 deficiency. Listen very carefully. In B12 deficiency, when the madam is not there, he is there with the methyl groups. This folate is there with the methyl groups, and he is trapped here in the liver and he cannot act and help the DNA, and this is also called as folate trap. Okay, right? In fact, now what happens, folate trap can happen here as well, and it can happen here as well. Okay, it can happen here as well. Now here what happens, you see what happens. In some people you have a deficiency of the enzyme which is dihydrofolate reductase, and when in certain people dihydrofolate reductase is not going to be present, the tetrahydrofolate would be stuck in the dihydrofolate form. You see, it doesn't have its 2 hands And how will he act again? He needs to act again and again, and he will not be able to act again. He would be stuck here without the limbs, and you see again our good old folate is trapped. Always remember, in certain people we can have the deficiency of this enzyme, which is dihydrofolate reductase. In fact, later on in pharmacology we'll take a look at certain drugs as well which inhibit this enzyme, which is dihydrofolate reductase. And dihydrofolate reductase is very important, because what it does is it reconverts the dihydrofolate back into tetrahydrofolate, so he can come back again and help the dividing DNA. Okay, in the meantime, when we are talking about madam here, isn't it? When we are talking about B12 madam here, she also happens to play a role. See, the folate was actually helping the DNA. Until now I had told you that the madam B12 was having an indirect role basically here in helping out the folate. But what is the purpose of madam B12? There is one very important purpose of madam B12, and that is in the metabolism of odd chain fatty acids. In the metabolism of odd chain fatty acids, which we'll describe in detail in biochemistry, we have a substance which is called as propionyl coenzyme A, and propionyl coenzyme A needs to be converted into malonyl coenzyme A. Okay, and malonyl coenzyme A will finally be converted into succinyl coenzyme A. Okay, that's the reaction which you need to remember. This is the reaction. Now what happens is the malonyl coenzyme A is not a good substance, and what happens that B12 here is required for the conversion of malonyl coenzyme A into succinyl coenzyme A. Now in B12 deficiency there would be an increased level of malonyl coenzyme A because it is not being converted into succinyl coenzyme A. This malonyl coenzyme A can get starting, it's not a good compound. What can it do? What can it do? What can it do? I'll show you. What happens is that, let's say this is a nerve fiber. Now the nerve fiber is going to have myelin over it, and this malonyl coenzyme A is attracted towards these myelinations, and it starts getting deposited over these myelinations and stripping them out. Okay, so because of this, what happens is that there is nervous system demyelination. This compound will go, the malonyl coenzyme A, and just like a glue or like a wax, you've seen those females getting waxing strips done, right? So just imagine this fellow will go, it will just take out the whole myelin, isn't it? It will cause demyelination. What is malonyl coenzyme A doing? It is causing the demyelination, and this demyelination can happen in the central nervous system, and this demyelination can happen in the peripheral nervous system. It can happen both ways, and mind you, this is a permanent damage. Once this damage happens because of B12 deficiency, this is irreversible, and the posterior tracts of your spinal cord and the lateral tracts of the spinal cord mainly are affected because they are myelinated the most. Because of the faster speed of conduction, they are destroyed, and in fact the first sensation which is to go is the proprioception sensation. Okay, one more reaction which is taking place because of the B12 is the conversion of homocysteine into methionine. Okay, we'll write this. Another thing is being converted with the help of B12. It is homocysteine, and homocysteine needs to be converted into methionine. Again, the catalyst which plays the role is B12, and when you have a deficiency of B12, what happens is that homocysteine levels also start to go up, isn't it? Homocysteine levels will also start to go up because they will not be converted into methionine. And now what happens, this homocysteine, where can this go? This is, let's say, your blood vessel or the endothelium. This homocysteine here will go and it will start getting deposited here on the endothelium, and it will obstruct the blood flow of the endothelium, and this can also result in vascular phenomenon and heart attack type of phenomenon, which are ischemic heart disease. Okay, so what else can happen? When this homocysteine can get deposited, atheromas can develop, and this can result in ischemic heart disease. So you see, two very important troubles are happening, one with the heart and the other with the brain. With the heart, you have this homocysteine which is getting deposited, and in the brain, the CNS and the PNS, you have this malonyl coenzyme A which is being deposited. In fact, what we do is we can measure the levels of this methylmalonyl coenzyme A in the blood, and we can measure the levels of homocysteine also in the blood. In fact, both of them are very good indicators that there is B12 deficiency. If you see these two increasing up simultaneously and there are certain changes as we had discussed, you just think about that there might be a B12 deficiency. Okay. Now, what we are seeing is that the cells basically are becoming bigger in size because the cells are immature in size. In fact, if you see the DNA was there and the rapidly dividing RBCs needed it. RBCs were initially bigger in size and ultimately matured into these smaller cells. Now, when these RBCs are not going to be matured because DNA is not there to act, because of a deficiency of folate, or maybe indirectly because of B12, then the cells are larger, and when these larger cells go into the circulation, they are called as macrocytes, and when these cells are present in the bone marrow, they are called as megaloblasts, and the anemia combined is called as macrocytic megaloblastic anemia. Okay, in fact, there are some other conditions also where macrocytosis can be seen. So, when we talk about macrocytosis, when there is immature cells going into the circulation, these conditions can be remembered by an acronym which is LHMC. You have a famous medical college in Delhi which is called as Lady Hardinge Medical College. So just remember, LHMC is Lady Hardinge Medical College, and when we'll talk about that, we're going to talk about macrocytic anemias. What is L here? L basically is liver disease. Okay, so liver diseases, in liver conditions and liver diseases, we can have macrocytic anemias. What is H here? H here is hypothyroidism. Okay, it is hypothyroidism. Then what is the M here? We've already talked about it is megaloblastic anemia. Yes, isn't it? We've already talked about the M here, which is megaloblastic anemia. C are the cytotoxic drugs. Okay, C are the cytotoxic drugs, and these can be methotrexate and they can be phenytoin as well. What can be there? It can be methotrexate, it can be phenytoin, which are the cytotoxic drugs. So just to compare with the conditions of macrocytic anemias, I have written a table here for microcytic anemias as well, and this can be remembered by an acronym which is SITA. Okay, microcytic anemias can be remembered by an acronym which is SITA, which is SITA. S is sideroblastic anemia. Okay, so these conditions basically are just the opposite of macrocytic anemias. In macrocytic, we had these immature bigger cells, and in microcytic, we'll have these smaller cells which are maybe over mature cells. So microcytic conditions, S is for the SITA, S is sideroblastic anemia, I is iron deficiency anemia, iron deficiency anemia. And then we have the T here. T signifies thalassemia. Okay, and finally we have the A, and this signifies anemia of chronic disease. What does this signify? This signifies anemias of chronic disease. Yes, so we will not confuse with macrocytic anemias and microcytic anemias. For macrocytic anemias, we have the acronym LHMC, which is Lady Hardinge Medical College, and microcytic anemias, we have the acronym which is SITA. S is for sideroblastic anemia, I is for iron deficiency anemia, T is for thalassemia, and A is for anemia of chronic diseases. Now the next thing which we are going to talk about here is pernicious anemia. Now the question arises, pernicious anemia is nothing but a counterpart of megaloblastic anemia. How does it happen? So for this to happen, what I will draw is, I will draw a simple GIT here.